think this is a cool topic because I think a lot of you, or some of you, might go on to careers in working in local, state, local, or government public health departments, where surveillance might actually be a very important part of what you do every day. And it's when people think about infectious disease epidemiology, often what they think about is surveillance and epidemic response. So this is sort of what we do in a lot of ways. And the reason that we do surveillance is because we want to know what we don't know. How do we know when an outbreak has happened? How do we know when some sort of new pathogenic threat has emerged? How do we learn about changes in seasonal patterns of infectious diseases, for example, influenza? How do we learn about changes in virulence, entry of pathogens into new regions, new populations? And the answer to all this is public health surveillance. And so the general public health approach is to look to see what's the problem, find out what's the cause, risk factor identification, find out what works through intervention evaluation, and then figuring out how to do it through implementation, go from problem to response. And the root of all this, of all our sort of gumboot epidemiology, is surveillance. Like, we have to know like that there's something to look at to be able to look at it. So all the people at your local public health departments, they're doing actually the most important part of the process. They're collecting the data that we need to be able to do our work. So what is public health surveillance? In this book, Field Epidemiology, and this is the definition the CDC accepts, is the ongoing systematic collection, analysis, and interpretation of health-related data, essential to planning, implementation, and evaluation of public health practice. And the key words here are ongoing and systematic. We have to keep collecting data in a consistent manner over a long period of time to be able to spot new or changes in existing public health threats. Why is public health surveillance needed? I think, I just said it, in the sense that it provides the basis for epidemiology and public health response, but it also can serve as an early warning system, identify new public health emergencies, like an outbreak of foodborne illness in a local restaurant, for example. I mean, these things can be picked up by public health surveillance. Guide public health strategy and policies. They provide data and information for policymakers to create new policy for public health. Document impact of an intervention or progress towards specific public health target goals. So, like, is what we're doing having an impact? Is it working? Understand, monitor the epidemiologic condition to set priorities and guide public health policy and strategies. And like we just said, it collects data to inform policymakers. This is from the WHO. So this is not just speaking domestically, this is speaking internationally, worldwide, of why public health surveillance is needed. And when you talk about public health surveillance, there's really, no bottom of the totem pole, so to speak. No, it doesn't matter like how small like a clinic is that is just like sort of diligently on a daily basis, logging like cases that come into a tiny public health facility with no power or water in the middle of the Congo or wherever. There's no difference between that and some giant body like the CDC or the WHO, which is collecting all this data. Every stage matters, and every player matters. So effective public health surveillance systems, they are tasked, and they do, the detection and notification of health events. They put the data out there and collect and consolidate pertinent data. They investigate and confirm cases or outbreaks. They do routine analysis, and they create reports, and they feed back information to those providing the data. This is really important. Is making sure that your analysis goes back to the people you got it from, right? So, we're depending on communities to inform us of different public health events. And so we want to make sure that that data goes back to them and helps them as well. And also feeding forward. So it's feedback and feeding forward. Feeding forward is forwarding the data to more central levels, like, to, the state health department or the CDC, or the WHO. And also public health surveillance systems report data to the next administrative level. So we can have a collection at every level. There's data collection and consolidation and data validation and insurance of data quality. So again, like I said, no level is less important than another, where it's every single level of this process is just as important as everything else. Public health surveillance best practices. This is from the CDC, aspects to address when evaluating existing surveillance systems. You look at data types that have already been collected and are available to generate consistency. You ensure that data is recorded in a timely manner. We have to make sure that the things we're recording are recorded when we want them. Just ensure data completeness. We have to ensure the quality data, that all information that's required is filled in. We have to also be flexible. We have to make sure that our systems can be modified or changed when needed. Having an essential equipment is important: laptops, cell phones, internet connections, all these different things, and also to qualified staff. So, I mean, you can obviously see that some of these things are going to be easier in more resource-rich areas than resource-poor areas. Like I've been to health facilities in, rural Malawi or Tanzania or Kenya or Gambia or wherever, where there's no power. There's no running water in the area except for a well outside, and data is collected on paper sheets by hand, by people with varying levels of education, and these data sheets can be stored. Like the worst I've seen was I went to a facility in Kenya, and all of the case sheets of a health facility were stored in the latrine. And half of them were moldy, and rats were eating on the rest. But they were there, and we had to pull them out and pull the data off of them. And some were legible, some were not. But this can go up to like hospitals like UMass General, which probably has extremely is probably extremely equipped to collect and keep data and report those to UMass Public Health. So it can be all over the place. But we're always striving for best practices no matter what level we're at. So there's two types of public health surveillance. First is passive surveillance, where diseases are reported by healthcare providers. So cases come to the hospital, they're sick, they're tested, and the hospital or clinic or whatever reports the presence of case to whoever they're required to. The limitations of this are that it requires that cases come to a facility. So you're going to miss a lot of cases that don't come to the facility, or seek healthcare elsewhere. Most people seek healthcare at their local pharmacy by buying over-the-counter medications. That's usually the first step of the process. Then only after all these things fail do they go to an actual hospital. So if it's a mild sort of presentation of disease, then, they might, get over it and not go to the facility at all, and that case was never found. So passive surveillance is cheap and easy, provides great data on a consistent basis, but that data might be somewhat incomplete. Active surveillance: health agencies contact health providers seeking reports. Active surveillance can also be going into people's homes and asking questions regularly, basically finding cases in an active manner. This ensures more complete reporting of conditions. It's used in conjunction with specific epidemiologic investigations. So passive, active. You're going to hear these words a lot. Public health surveillance: the CDC and state departments of health have extensive notifiable disease lists. Some are mandatory, some are just suggested. And these are great because they allow temporal and geographic tracking of trends. They all have to report these things in some cases. And so this means you're going to get, never complete data, but comparable data across time and space. Infectious diseases are firmly rooted in specific times, places, and cell populations, and recall biases in this case are generally, but not wholly limited. So they're reporting what comes in. They're not depending on asking people what happened in the past. Together, these allow for rapid flagging of many emerging situations. So cases come in, we see spikes in cases, and this can set off alarm bells. So surveillance data streams, getting the word out there. And this is what we want. We're public health people, and public health people are communications people. I'm gonna drink some water real quick. Thank you. Surveillance data goes out in official disease and health notification systems, weekly reports through bulletins or web-based media. If you signed up for notifications like from ProMed, for example, these are going to give you regular bulletins or regular access to places where you can find bulletins. And even at your local level, there might be systems in place to disseminate information to the public. CDC does a great job of sending out bulletins and making data available. Health personnel themselves can get out there and start, sending messages out to people, either through going and directly engaging with communities and having sort of events where they disseminate information, or through blogs and social media. That's another great way of getting the messages out there. I don't know how many of you follow Twitter and these things, but public health Twitter is there's a lot of people out there that are doing a great job getting information out there in a respectable and timely manner. Laboratories can provide notification. So SARS is an example. Labs picked up on this. Newspapers and media, ProMed, subscribe to that. Social media updates, all these things. So we want to get the word out there, and in 2020, there's so many different ways of doing this. So, definitely when you look at your career and you're moving on, think of yourself as a source of public health information, all of us, even, in the master's, while you're still going through your schooling, you're still sources of public health information to people, and even just the people around you in your own friend network. So get the message out there for sure. Epi reports, there's tons and tons of different formats. Like, here is, a map, with case numbers from the WHO for outbreaks and other emergencies. And these are different types of outbreaks in sub-Saharan Africa. ECDC, the European version of the CDC, puts out weekly reports and in this list format. So you get nice maps and visualizations, and those are really awesome, especially for getting the message out to lay people. Written reports are great too, especially when you want to send those out to policymakers. So information types, there's case-based surveillance, regular review of routine surveillance data, and these are usually limited to reportable diseases or existing surveillance projects. So cases come into a health facility, and they're identified as being a case and report into a reporting system. And so this is one way of doing it. And there's event-based surveillance. So rumor register. Rumors can be important with public health. If people are saying that there's people out there that are coming down with this particular type of symptomatic profile, and you're just sort of hearing words on the street, or seeing things on social media, these can actually be kind of good for identifying, new outbreaks or new emerging pathogens. I mean, don't discount the rumor mill for sure. Social media, again, things that people say on social media that are spreading around, about sort of, medications, outbreaks of things, different sort of events, things they've noticed. I mean, these are all ways of knowing. Traditional media, obviously an important source of information. So these event-based surveillance, people are sort of keeping their eye out for stuff that's going on, is important. Definitely don't disregard it for sure. People will talk about their health. they will talk about health concerns in public and online. And because everyone, people become worried. And this is really important in sort of not only domestically, but in developing country scenarios where data collection might not be the best, and sort of reportable diseases that are limited to certain things, and those diseases might be limited to certain lab capacity. And so in developing countries, like listening to what people say can be really helpful in figuring out if there's something going on or not. Massachusetts, since most of y'all are in Mass or somehow connected to Massachusetts, these are their list of reportable diseases. So they have this list of reporting immediately. Clinics, healthcare providers have to report these diseases within 24 hours. Like anthrax is really serious. You want to get that reported as soon as possible. Botulism, brucellosis, cholera, all these different things, mumps, pertussis, malaria, typhus, rubella, tetanus, all these things are extremely serious and should be reported immediately because there might be other cases related to these. Other pathogens, they're reportable through laboratory testing, which takes time, often. Include these diseases here. It's like Lyme disease, listeria, salmonella, all these different things. The lab will be tasked with reporting these things: Hep B, C, D, E, influenza. Generally speaking, facilities can pick up on these. Rabies is something they can definitely pick up easily, but there's some that have to go to specialized labs. So you basically, if you see, for example, some of these STIs, you report directly to the Massachusetts Department of Public Health, Bureau of Infectious Disease and Laboratory Sciences. Call them up, when you've seen, chlamydia, gonorrhea, syphilis, all these different things. So these are the list of diseases. Some states have more, some states have less. Some localities have more, some localities have less. The CDC itself, or the National Notifiable Diseases Surveillance System, list these as—
Can I ask a question?
Yes, please.
So I was wondering, what is reported in these surveillance reports to the state? The patient's identity is given, or is it protected?
Good question, and I'm actually not sure about that in the case of Massachusetts. I actually don't know that. In Michigan, I think rudimentary information is reported, like age, gender, sort of location of diagnosis. Names, I do not think are reported generally, just to protect patient privacy. I'm going to have to get back to you on that in the case of Massachusetts. And I know that it does vary state by state. And this is like, I think this issue of ethics and surveillance is incredibly important. Protecting patient privacy and identity while protecting public health is a difficult balance to make. In the case of like an HIV infection, for example, where the contact tracing has to be made, names obviously have to be, phone numbers have to be reported to do that. And I don't quite know what, in the case of COVID-19, how long, those data will be kept. So great question, difficult answer. I think, answer would be, it depends.
Okay, so, thank you.
Yeah. And we'll have a whole section on ethics and privacy later, and I'll make sure to bring in some information about this. So, National Notifiable Disease Surveillance System. That's a great question. Thank you very much for that. Keeps data on cholera, Giardia, Hep A, all these different things. This is at the national level. Official disease notification systems are many. CDC Notifiable Diseases has 120 plus diseases and syndromes for mandatory reporting. Flu surveillance, sentinel sites, flu ILI surveillance at 400 labs throughout the country and 3,500 registered outpatient care providers. And these are mostly intended to assess temporal trends, see, if there's large spikes in influenza-like illnesses over time. Weekly reporting through the weekly epidemiological record, global aggregators, CDC, MMR, weekly updates to the WHO. There's all different kinds of systems around the world. Reporting to WHO is required for cases of smallpox, polio, human influenza caused by any subtype, severe acute respiratory syndrome, and I'm pretty sure that COVID-19 is on this list now. So they're collecting worldwide data. And so polio is there obviously because we're sort of getting close to eliminating polio for good, like we did for smallpox, and it's important to know where new polio cases are coming from because there are very few around the world right now and only appear in certain places to direct polio vaccination efforts. The system of notifiable diseases works quite well in spotting diseases. So here, 2018 Massachusetts arbovirus daily update, cases of West Nile and Eastern equine encephalitis. Caught cases there, caught mosquito sample cases and human positive cases there. And this is good for reporting. We recently had an outbreak of Triple E here in Michigan. And data came out immediately. I was quite impressed with it. And sometimes it doesn't work. There are going to be major differences in acute respiratory infections reporting at state levels. Some areas are better than others. Yeah, it varies state by state. We live in a sort of a unique country, where so much of these powers are delegated to the states and sort of quality varies. But we're obviously, pushing to have consistency around the country. So I guess the question is what sort of challenges to timely and accurate reporting can you think of? And sort of like, I'm interested in hearing what you think. I'm not hearing anything.
I think unless it's a mandated thing, people will not be very good with reporting unless there's a penalty to it or something like that.
Yeah, totally. I mean, there has to be some sort of system of accountability, making sure that the people who are tasked with reporting these things actually do the work. If it's voluntary, you can expect that there'll be shortfalls across the system for sure. Yeah.
I had a related question actually.
Sure.
Two probably, but since the U.S. is not linked to WHO anymore, will the U.S. report to WHO? Is that a requirement or is it just a country's?
We are still reporting to the WHO. At this point, we have only stated that we're going to leave. We have not left. And we're still, at this point, reporting to the WHO. The head of the CDC indicated during one of the House hearings that the CDC is committed to reporting to the WHO, even in the event that the United States leaves.
And that is a voluntary thing, right? Countries are not required to report it.
Yeah, countries are not required to report. The WHO really has no sort of punitive power to sting countries if they don't.
Mm-hmm.
So you can imagine, countries like North Korea, for example, like they don't have to report if they don't want to. I mean,
So what are the advantages to a country to report something? Yeah. Especially something serious like, I don't know, deadly or whatever.
Well, like in COVID-19, for example, like the advantage to China in reporting COVID-19 cases early to the WHO allows that information to be disseminated throughout the entire world to raise the alarm bells with public health organizations around the world, and also to share information so that researchers can develop strategies to either diagnose or create medications for COVID-19. So China is obviously, motivated, incentivized to do that because they can, feed into the worldwide research infrastructure for sure. Outside of that, I mean, countries like, reporting to the WHO and reporting sort of like malaria burdens, for example, will directly impact their level of funding to support, for example, malaria programs. So countries in sub-Saharan Africa, for example, are incentivized to report to the WHO because they can then, use that as a means of showing that they do have a malaria burden and receiving funds proportional to that.
Great, thank you.
Yep. So what other challenges can y'all think of?
Well, I would think one challenge would be just healthcare providers having time to report. Often they're not paid for time spent reporting some of these diseases.
Huge problem, huge problem, especially in developing country scenarios where, people are poorly paid, they're extremely busy, they're seeing high patient loads in comparison to their own capacity. And it has been my experience working in sub-Saharan Africa that the biggest challenge to getting accurate data from health facilities is time and money. People just don't have time to fill out all the forms as well as they could. There's nothing to the idea that people are just slackers and lazy or whatever and just don't want to do work. That's ridiculous. People are just incredibly busy. You go to any facility, in Kenya in the morning, and there's a line out the door with mothers with kids, waiting for various things. And, maybe at best there's one doctor on hand, and there's a, poor lady, at the desk who's tasked with responding to all these people, some of whom are angry, some of whom are annoyed and have been waiting a long time. So yes, absolutely. Human limitations. We have to be sympathetic to that. If some of us go out in our public health careers, we will definitely be interacting with people who are facing those challenges. Any other ideas? Go ahead.
Maybe some problems with not having, at least in the US, centralized data. And so there's incredible heterogeneity in terms of reporting and what's made public.
Oh, yes, absolutely. And this, when Obama was elected back in 2008, one of the things that the Health and Human Services was tasked with was creating an electronic record system for hospitals. And part of the motivation of that was to standardize record collection throughout the country and create a central database. And it was a huge controversy. People opposed it, which to me, as a public health professional, I think is just crazy. We need to have good data to be able to do our jobs. But there were issues of privacy and also cost. Hospitals were having to pay for it themselves, and also were having to hire people to do it. And doctors were very concerned that they would spend most of their time filling out forms rather than seeing patients, which, if you've gone to a doctor in 2020, which I'm sure most of you have, if you're old enough and can compare that to 20 years ago, there are a lot more tapping on the screen by physicians than there used to be, and it's a lot of extra work, which sort of leads us back to the previous point too. So yes, absolutely, it's a huge problem here in the United States, and hopefully, we're obviously getting better at it, but we can do a lot better, for sure. Anything else? It's great to hear from you all. Okay, cool, great points. Thank you very much. Another way of collecting data is use social media trends as a tool for surveillance. I think this is really cool. When this first came out, back in the late 2000s, I thought it was really great. You know, you can use Twitter, for example, to track levels of disease activity for influenza, as was done, I don't know what year this was, during the H1N1 pandemic. Accurate estimation of influenza epidemics using Google search. And so Google has this thing called Google Trends. And basically what it does is it tracks search terms, and gives you the data over time. So this is people searching for things about influenza. And this is from 2004 up to the present. And you can see that spike, 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 seasonal spike, seasonal spike. Like here's January, right? Seasonal spike. This is how the influenza season works. And these are just searches. These are not confirmed cases. And this also can give us some ideas about spatial heterogeneities, where outbreaks might be occurring. You know, does, you know, sort of North and South Dakota, you know, they have heavy searches for influenza. So perhaps there's a serious outbreak, you know, epidemic there. And when we look at COVID-19, we can see, we can look up, you know, people searching for COVID-19, and here we go, hump, goes down, hump here. And then when you look at COVID-19 mortality, hump here, hump here. So same sort of pattern. People are searching for the things that they're concerned about based on the things that are happening around them. So this is sort of a systematized version of the rumor mill in a lot of ways. And you can try this for all different kinds of diseases and come up with all different kinds of interesting results. Because, like, again, not all diseases are reportable, you know, but people will sort of respond to the different things they hear in the media. One thing I did a project on a few years ago was looking at food insecurity and looking at number of newspaper articles about food riots around the world and seeing how that correlated with different health indicators. And it came out sort of with really some interesting results. Obviously, doing studies on nutrition is very difficult. Maybe some of you have been involved in those kinds of studies. But, you know, like when people are hungry, they get angry and they tend to, you know, demonstrate against their government when there's not enough food or food is too expensive. So newspaper articles on these things were a good way of getting at that. So all different kinds of sources of data out there. So, you know, when you're going out in your careers, you know, don't just think of the traditional, you know, sort of official sources. There's also sort of non-traditional sources out there as well that provide some really, really great information.